Good morning, or it's good morning to me. I'm going to be recording acute respiratory infectious disorders in children, primarily focusing on RSV and some of the treatment modalities and things to look for respiratory distress. And when we get to that point, if you have any questions, any concerns, once you view the YouTube, please let me know by sending me an email, and I'll get back to you as soon as I can. Thank you, and have a great morning, afternoon, evening, whichever it shall be. All right, let's look at infectious disorders. Whoops, maybe. Try that again. All right, let's look at infectious disorders. If you don't have your PEDS book open, you'll need to have your PEDS book open. We're going to be talking from chapter 23, and then we're going to go back and pick up just a few things in chapter 22 that we skipped during growth and development, and I said we'll go back and get this later. Well, later's here. All right. One of the things before we get started that I want you to look at is I have posted a handout on retractions and where to look for those retractions, whether they're intercostal or subcostal. So you'll need to know that for test purposes. Also, when we're thinking about pediatric differences in the A&P respiratory system compared to that of the adult, that's very important that you know those differences. So I'm going to go over those real quick. If you think about it, number one, and you'll need to write these down, infants up to 4 to 6 weeks are primarily nose breathers. So that's a big significant fact. So if they get a cold when they're really, really young and it stops up their nose, they're not going to be able to breathe. So number one, infants up to 4 to 6 weeks are primary nose breathers. And actually, even up to age about 6 months, they like to breathe through their nose primarily. But almost completely 4 to 6 weeks. Number two, the tongue is larger in proportion to the mouth, making airway obstruction more likely in an unconscious child. Number two, the tongue is larger in proportion to the mouth. Well, if it's larger than proportion to the mouth, then airway obstruction is going to be more likely if that child becomes unconscious. Number three, smaller lung capacity and underdeveloped intercostal muscles give the child less pulmonary reserve. Smaller lung capacity and underdeveloped intercostal muscles give the children less pulmonary reserve. So they don't have a backup system. They don't have this increased space. They have nothing. So if something happens inside their lungs, they have such a small capacity, it doesn't take much for them to go awry. Higher respiratory rates. Number four, higher respiratory rates. Well, if you've got higher respiratory rates, then the demand for oxygen in a young child makes hypoxia easy to occur. So if they already got higher demands and then they have an infection on top of that requiring even more higher demands, then hypoxia can easily occur. All right, next, airway is smallest at the cricoid, C-R-I-C-O-I-D, for children younger than 8 years old. If you think about it, it's almost like a funnel shape, and only 1 millimeter of edema can compromise the airway in these children, up to about 75%. So 1 millimeter of edema compromising up to 75% tells you how small that airway gets. So airway is smallest at the cricoid for children younger than 8. Next, they have a smaller, narrower airway. That makes children more susceptible, if you think about it, to obstruction, to respiratory distress. Next, infants and children appear barrel-chested when you look at them. Infants and toddlers appear barrel-chested. And lastly, children rely heavily on the diaphragm for breathing. If you'll remember, abdominal breathing is normal for the child up to age 7. Abdominal breathing is normal for the child up to age 7. And of course, they are more prone to retractions as well. And that's one of the symptoms that you look for. So make sure you look over that as when you're getting ready to look at your stuff. Alrighty then. Causative organisms. Well, the most common when we think about infectious disorders, upper respiratory tract infections, are viruses. and especially RSV. In fact, up to 75% of all cases of bronchiolitis in infants is caused by RSV. Now, there's also some bacteria and some other things that cause it, but these are the main ones, the viruses. And you see the adenoviruses, influenza, enteroviruses, and rhinoviruses are also guilty. But the primary one that we're going to see is the RSV. All right, here's some common bacterial organisms. Again, anything from strep to Haemophilus to pneumococcal. When we think about the therapeutic management of upper respiratory infections, we really need to remember 4 things. Bed rest until free of fever. Bed rest until free of fever. Now, you would think this would be a luxury, but with children, it's not. Keeping them on bed rest is sometimes not easy. So you have to have lots of diversional activities, distraction, and things to keep their mind doing other things that's appropriate. Number 2, encouraging fluids. This is the best method for liquefying thick secretions. Liquefying thick secretions. Number 3, manage the fever. Tylenol and ibuprofen. If you don't remember those normal dosages, needs to come back and get you. Tylenol, 10 to 15 milligrams per kilogram. Tylenol, 10 to 15. Ibuprofen, 5 to 10 milligrams per kilogram, depending upon the fever. Remember, about 102.5 is your breaking point. Anything below that mark is 5 milligrams per kilogram. Anything above that mark is 10 milligrams per kilogram. And finally, comfort measures, just making sure the child is kept comfortable. So that's really all we can do as far as mainly our therapeutic management with us for respiratory infections, because the number 1 cause was viruses. Now, parents don't like to hear that word. I have known parents that demanded antibiotics when the doctor's sitting there saying, this is a virus, let it run its course, but they're running fever. They've had fever for a week. I know lots of viruses that will make you have fever run for a week. So I think, again, we've created a monster here in giving the antibiotics when the physician knows that it is a virus that's causing it. All right, the signs and symptoms associated with respiratory infections. You can see there's several here. They're also listed in your book in Chapter 23 on page 708. Anything from fever to meningitis, and that may be the one that you're not as familiar with and don't know what that word means, and we'll go over that in just a minute. It's kind of like a pseudo meningitis or a false meningitis. And we'll go ahead, if you look on page 708, it says it's meningeal signs without the infection of the meninges. So you may have an abrupt fever, and then you may have headache and pain and stiffness in the back of the neck. But you actually do not have a true form of meningitis, just the signs and symptoms. So it's called a pseudomeningitis. Anorexia, vomiting, diarrhea, abdominal pain, nasal blockage, discharge, cough, respiratory sounds, and that can be different things from grunting. You may have nasal flaring, sore throat. This is on page 708 for complete details. And don't forget to look at that handout on retractions. All right, also at the beginning of the year, I gave you a handout that gave you the tips for remembering pediatric vital signs. Make sure that you go back and look at that because we're talking about respiratory, so that will come in very, very handy. I will try to remember to post that again as well for you. All right, some general terminology that you need to be familiar with. Respiratory failure. That's the inability of the respiratory apparatus to maintain adequate oxygenation of the blood with or without carbon dioxide retention. And this came straight from your book. Respiratory arrest is the cessation of respirations, and apnea is absence of airflow. Apnea usually is cessation of breathing for greater than 20 seconds average. Now, if they're symptomatic, they may have a shorter time frame for that, but it's when you go with periods without breathing. Looking at the cardinal signs of respiratory failure, and you probably do need to be familiar with these. One of the things, if you even suspect that a child's having respiratory failure, that you want to get in there and respond quickly. Vital organs like the brain cells will begin to die without proper oxygenation, so you want to make sure that you're oxygenating the child well. As far as the cardinal signs that you're going to be looking for, the first 4 are the cardinal ones, and these are restlessness. Bells and whistles should be going off. If you have a child, a pediatric child, that is just extremely restless in that bed, that's a clue. Respiratory failure impending. Tachypnea, tachycardia, and diaphoresis. Those are not good when seen together. And of those 4, the earliest sign is restlessness. Other signs you may see is grunting, hypoxia, hypercapnia, retractions, and nasal flaring. If you are not familiar with grunting and nasal flaring, then I would suggest that you go to YouTube and you look up grunting and nasal flaring, and you will see all kinds of videos that gives you examples so that you can actually hear the grunting and see the nasal flaring. Now, there's early, moderate, and late signs, and those are things that you need to be watching for. Again, when we're talking about respiratory problems, we're talking about early on, we may start seeing like an increase in pulse and respiratory rate. An increase in pulse and respiratory rate. Then, for moderate distress, then we're getting into starting to see that increased restlessness, visible efforts to breathe. They're actually starting to struggle. It's the grunting, some of those things you may see, the nasal flaring. And then late signs, the big one that you're looking for is the difference in the coloration of the skin. The skin's going to become cold and clammy, and they'll become cyanotic. So you walk in and a baby's cold and clammy and cyanotic, that's late signs. You better be doing something quick. All right, the major complications of respiratory distress is respiratory acidosis. And when do you know if someone's in respiratory acidosis? If I need to put back up the ABG article, if you'll email me, I'll be glad to do that for you, because there will be ABGs on this test. pH less than 7.35 would be acidotic. If the pH is PaCO2 or carbonic acid is greater than 45, carbon dioxide, then that is acidotic. Now, a lot of times when you check this, sometimes you're going to check the bicarbonate, it's going to be normal. Why would it be? Well, if it's not had time to compensate yet, if you'll remember, the kidneys take hours to days to compensate. They don't get right on board like the respiratory system when it's in trouble. So that's why, because it takes longer for them to compensate. Coughing. Coughing is a defense mechanism that we have, and it's one way we have of actually maintaining clear airways. And it is important that we assist patients to cough effectively. And we went over that when we went over that in STEM's lab, so I know you know how to do that. Now, as far as medications, we can give those that increase secretions, those are known as expectorants. Those that decrease secretions, those are known as anticholinergics. Those that thin the secretions, those are your mucolytics, and those that depress the cough reflex, the antitussives. So as you can see, even though we think of suppressing coughing as something simple, there's actually a lot of different medications for that. Those that increase secretions, your prototype is like Robitussin, and we're very familiar with Robitussin. Those that decrease the secretion, your prototype is like atropine, they dried up. Those that thin the secretion, your mucolytics, is like your Mucomist, and that's also an antidote for acute Tylenol poisoning, by the way. And those that depress the cough reflex, antitussives. That would be like your Tussilin Pearl drops would be an example of that one. All right. Is there complications of a persistent cough? Yes, there are complications of a persistent cough, and sometimes we don't think about those. Insomnia, if you think about it, it can keep you up at night. Exhaustion, complete exhaustion from coughing so much. Some people cough to the point they vomit. So number 3 vomiting. Number 4, and this one's my favorite, urinary incontinence. Of course, I can do that without coughing. And number 5, rib or muscle trauma. You can actually pull some muscles because of coughing. And finally, fainting. People have coughed till they have fainted. So insomnia, exhaustion. We have insomnia, exhaustion, vomiting, urinary incontinence, rib or muscle trauma, and fainting. All right, there are procedures for maintaining respiratory function. We have oxygen therapy, humidification, aerosol therapy, artificial ventilation, and intermittent positive pressure breathing. These are covered back in your other chapter. And if you will look on page 687 through 693 with me, we will go over those. All right, the goal of these therapies, regardless of which one we're using, is to provide sufficient amounts of oxygen to the tissues so that normal metabolism can occur. To provide sufficient amounts of oxygen to the tissue so normal metabolism can occur. So regardless of what we're doing, this is what we're wanting to get to, okay? As far as oxygen therapy, if you will look on page 688 in your book, page 688, you'll see it shows a picture there of what's called a plastic hood. I'm sorry, I didn't finish this one. That was the goal of oxygen therapy. Sorry, the goal of oxygen therapy is, let me see where I'm at. No, let me go back. Sorry. Getting ahead of myself. Imagine that. All right, let's go talk about each one of these. Oxygen therapy. Okay, I finally got my story straight. The goal. When we're talking about oxygen therapy, the goal is to provide sufficient amounts of oxygen to the tissue so that normal metabolism can occur. Done told you that. So it's to treat hypoxia. The best tool for determining the need for oxygen, of course, is ABGs. Wrong. It's O2 sats. We want to check O2 sats. O2 sats are oxygen saturation, and if you'll remember, on the oxygen saturation, we get concerned when it gets low. It should be 95% or greater. And I say that because a lot of people think the best tool for determining the need for O2 is ABGs. But remember when we talked about the ABGs, we said that we only look at 3 things to determine acid-base imbalance. That's the pH, the carbon dioxide level, and the bicarb. We don't look at the oxygen. If we're wanting to know about the state of the oxygen, we need to do a pulse ox. Okay. Hypoxemia, of course, is defined when our arterial blood gases get low, our saturation drops below. Really, it just depends upon what's going on with the patient, because there are times that it's normal to have a lower than normal pulse ox, like your COPDers. But normally, if your oxygen saturation is getting below 90, we really are concerned. Pulse oximeters, and we also know what those are used for, to measure the oxygen saturation level. The waves of light in a sensor are placed upon either the finger or the ear, can be on the big toe as well, and then it's displayed upon the monitor. So that's one of the things that you want to watch for. Now, nursing alert, your book tells you it's important to make certain that sensor connectors and oximeters are compatible. Wiring that is incompatible can generate considerable heat at the tip of the sensors. Pressure necrosis then can occur from the sensors attached too tightly. Therefore, inspect the skin under the sensor frequently. So it shows you a picture on page 688 in your book of an oximeter sensor on the great toe. And you can note that the sensor's positioned with the light emitting LED opposite the photodetector. So the cord is secured to the foot to minimize moving of the sensor with a Velcro strap. But if you did not move that and you kept that on there for days and days and days and it was too tight, you could see how you could get a necrotic area forming. So make sure that you're using the right connectors and that you're checking that skin. All right, now let's look at O2 delivery modalities for peds. The plastic hood is on page 688. Okay, the plastic hood is on page 688. It talks about the oxygen tent and canopy also on this page, and we'll talk about nasal prongs and mask and when we should use which one for which one. All right, let's talk about the plastic hood first. This delivers actually the highest concentration of oxygen. We use it mainly on our newborns or early infants. You can give up to 100% oxygen. You'll have your O2 set on 10 to 15 liters to deliver it. Now, the disadvantage. Look at that picture on page 688. What do you think some disadvantages are going to be? They're difficult to assess the upper head, from the neck up because they're underneath the canopy. So things like the nails and stuff are hard to do. You've got to remove them for feedings. You can't feed them when they're under that. You need to monitor them carefully because if they're getting 100% FiO2, that can lead to oxygen toxicity. So they need to be monitored for that. So they're difficult to assess. They have to be removed for feedings. You need to monitor them carefully for O2 toxicity. Now let's look at the oxygen tent or canopy. I actually don't think your book took the picture out of those. Most of you are familiar with an oxygen tent or canopy. If not, then again, I encourage you to Google and to look at that. Okay. It is the best method of delivering O2 beyond early infancy. It is the best method of delivering oxygen beyond early infancy. Now, it is difficult to control and maintain above 40%. And that would be, again, your oxygen set at 10 to 15 liters. Why is that? Well, there's several reasons why. Nursing itself. Sometimes we have poor planning and we go in 2 or 3 times to make assessments and then do meds and then do something else instead of doing it all at one time. So when you're open, closing that tent, makes it very difficult. So you need to keep it closed and sealed, and that can be a major problem. If you think about it, oxygen is actually heavier than air, so it settles on the bottom. So every time you open that, the oxygen is being released. Keeping the child warm and dry is another problem that you have to address. Keeping the child warm and dry, so you want to go in there and feel it every once in a while to make sure it's not getting too damp. And reactions to children vary. Some are okay with it, some want their parents in there with them, and sometimes parents have to get in there with them, and it's okay. You have to be careful about certain toys and putting them in there. It talks about that on page 688 on the nursing alert. Inspect all toys for safety and suitability. Vinyl or plastic, not stuffed items that absorb moisture or are difficult to keep dry. The high-level oxygen environment makes any source for sparks, mechanical or electrical toys being a potential for fire hazard. So keep that in mind. Again, they're hard to assess and it does require maintenance. You got to go in and change the tubing out every so often. You got to make sure that it's staying humidified, make sure that it's staying cool. So there are some issues with that. All right, what about the nasal prongs or mask? Which is appropriate for the younger child and which is appropriate for the older child? And the answer is truly depends. Now, a lot of times your younger children can tolerate the mask a little bit better than the older children because the older children get to where they actually pull it off because it bothers them. It feels like they're smothering, I guess. So, as a rule, with the mask, the younger children, and with the prongs, the older children. But there may be times that you have to use the mask with an older child. Okay. Oxygen toxicity. I said you have to watch for oxygen toxicity. Now, what's scary about watching for oxygen toxicity? If you look at the signs and symptoms, cough, substernal distress, shortness of breath, restlessness, fatigue, malaise, decreased surfactant. A lot of these are the very reasons and signs and symptoms that put them under the tent because they needed more oxygen. So sometimes those are hard to catch. As far as oxygen toxicity, just something to keep in the back of your mind. Lungs and the retina of your preemies are the most vulnerable to high levels of oxygen and can cause damage to tissues. So you want to watch your preemies particularly for oxygen toxicity. All right, aerosol therapy. The main purpose of aerosol therapy. And I do want to reiterate, too, about humidification in there because we were talking about things being humidified when we're on oxygen. And if you're on just regular oxygen and nasal cannula, years ago it was strictly you were going to get humidified oxygen regardless, or nasal prongs, you may call them, nasal cannula, nasal prongs. But evidence-based practice actually says if your O2 is less than 1 to 2 liters, so if you're not getting more than 2 liters, and you don't have a respiratory tract infection, then you really don't have to have the humidification. But if your O2 rate is greater than 2 liters, if you're set at like 4 liters, you do have a respiratory tract infection, a trach, or some kind of nasal discomfort or dryness, then yes, you do need it. So it just kind of really depends. All right. So when we're talking about aerosol therapy, the main purpose of aerosol therapy, of course, is to deliver medications or humidity to both the mucosa of the respiratory tract and the alveoli. Deliver meds or humidity to both the mucosa of the respiratory tract and the alveoli, and particularly the lower respiratory tract. We're trying to get low down there. Some medications that may be used are mucolytics, bronchodilators, decongestants, and corticosteroids. Continuous aerosol therapy can be delivered via an mist tent. Bronchial drainage is more effective after aerosol therapy. So if you've got someone who's getting bronchial drainage and aerosol therapy, then you want to make sure you get the aerosol therapy. Usually performed by respiratory therapists, and it's a common example. This would be like giving an updraft. Now, a lot of your hospitals have cross-trained, and nurses are actually doing the updraft. So you may be employed at a place that you have to learn how to do those. Methods of delivery, there's the handheld nebulizers, and we've already been over these. We went over this stuff when y'all did your sim lab, so I'm not going to go over it a whole lot. Children, handhelds are hard for children less than 5. They can't coordinate well, so they do the blow-by method better by either putting on a mask or a mouthpiece as well. And then we've already talked about metered dose inhalers with and without spacers. They're portable, efficient, and usually less than 6 to 8 years we use for sure spacers. But you know, the latest evidence-based practices, really even adults should use spacers. So spacers are really the newer thing that's in. All right, what's your responsibility? Well, remember you want to teach them to rinse their mouths, especially if they're getting a glucocorticoid steroid. Document their response to treatment, the patient's tolerance to therapy, assessing breath sounds after therapy, and monitoring vital signs. So we do have some responsibility even if your respiratory therapy is delivering these. Inhalers, proper use with spacer. And remember, we kind of had this, well, let's say Rachel Landers is RN caring for Miss Caitlin Alexander, who's 8 years old, a newly diagnosed asthma patient who started on inhalers. She's given an order for Provental, which is a bronchial dilator, 2 post-QID, or beclomethasone, which is a corticosteroid, 2 post-QID. And if you'll remember, she needed which one first? She needed the bronchial dilator first to go down there, open everything up so that the steroid could do a better job on the inflammation. If you'll remember, you needed to wait in between puffs at least 1 minute, and then wait in between the different kinds about 5 minutes. So she's getting 2 puffs. It'll be a minute between puffs, and then 5 minutes between the meds to allow that time to actually work. So we did talk about that as well in our Sims lab. All right, let's talk about bronchial or postural drainage. Your book used to have really good pictures of this, but again, for some reason they have taken it out. So if this is something you're not familiar with, then I would Google it. But what it is, the purpose of it is it's instituted when there's a large amount of fluid or secretions in the bronchia. So particularly your CF patients with cystic fibrosis. And what it does is to help localize therapy to the involved segment. It requires various positions to maximize the gravitational flow. It's carried out 3 to 4 times a day. And when's the best time would you think to do postural drainage? Well, it's before meals or 1 to 1.5 hours after meals. And why is that? Well, if you think about it, you're getting all these secretions up, so it decreases the potential for them aspirating and vomiting. Now, it's difficult to apply to any setting. It can be individualized. They can make homemade boards and some other things, but it is a little bit, what can I say, the word? Trying on families at times because they have to do this whether they're on vacation, whether they're just going to grandma's. I mean, you can't just quit doing this 3 to 4 times a day. It has to be done that way every single day. It's more effective when it follows other respiratory therapy. And they will do 4 to 6 positions that's utilized over 20 to 30 minutes. So they'll put them in a certain position for 20 to 30 minutes. Then they'll flip them over and put them in a different position. And they're trying to move those secretions so that they can get those secretions up. And again, the major disadvantage was that it's difficult to apply in any setting. Chest physical therapy, if you're not familiar with this, please also YouTube it. But it's a combination of postural drainage and percussion. So you've got them in certain positions and then you're percussing their back. And if you think about it, if you were to cup your hand and then hit the table or hit their backs, what you would be hitting, in that area that you're trying to loosen those secretions. You want to perform that about 30 minutes prior to meals. To have the pulse ox on if they're having trouble, because sometimes those secretions, if they're real thick when they get them up, can cause mucal plugs and everything else, and you can get in some respiratory issues. Techniques used are anything from manual percussion to vibration, cough, forceful expiration, or breathing exercises to help get that up. The primary purpose of chest physical therapy is to clear excessive secretions. So you want to get those excessive secretions up. There's also now what's called a therapy vest, and that's the newest thing that's out there for cystic fibrosis patients. Artificial ventilation, we've already been over in ICU, so we're not going to go over this content. Just understanding ventilator function and be able to detect abnormalities. Also promoting the ventilator's effectiveness by positioning, suctioning, and emotional support as part of the RN's role. All right, so now we're to RSV. RSV, and there will be quite a few questions, and if you looked on your quiz, it's going to cover over RSV and cystic fibrosis. RSV, when we're talking about it, let me get to your book and get you a page number. I'm looking. All right, when we're talking about RSV, the incidence in small children under 2 years of age, and by 2, nearly 100% have actually acquired RSV. It mainly occurs in the very young, and it is debilitating. As far as looking at RSV, it is the major cause of viral respiratory disease in infants and children. It accounts for almost 40% of all your serious respiratory diseases and for up to 60 to 75% again of all cases of bronchiolitis. So it is very, very contagious. And again, by 2, nearly 100% of children have actually had RSV. And I still can't find it in your book. I'm sorry. It'll come to me here. Okay, finally, 723. All right, clinical manifestations of RSV. Early symptoms would be profuse rhinorrhea. That nose will pour. Fever, otitis media, and conjunctiva. So they will have these as the early symptoms or clinical manifestations of RSV. Later symptoms become, and when we see later symptoms, usually it's more at the moderate or severe level: cough, dyspnea, tachycardia, retractions, cyanosis, wheezing, and apnea. You can tell there that the signs and symptoms are getting worse. Now, when I say dyspnea, I'm talking respiratory rates anywhere from 60 to 100. So we're talking about these kids are sick. Transmission of RSV, direct contact with the infected secretions, usually hand to mouth, nose to eyes. Very communicable, but it's not airborne. It does live on skin surfaces for 8 hours, countertop 6 to 8, and tissue paper 30 minutes. Contact isolation, so you need gloves, gown, private room, and hand washing. Is this what's being done? For the most part, from what I see, it is what's being done. Treatment, mild to supportive. If it's mild, it's just supportive. Moderate to severe, then they're going to have to maintain that airway and oxygenation. First thing we're going to do is a cool vapor mist tent. So we're going to have to watch them for all those things we talked about earlier. Hydration, they're going to have an IV. Ribavirin is an antiviral agent that we're going to be used to treat moderate to severe RSV infection. RSV immune globulin, Respigam, we'll talk about that. And Synagis, we'll talk about that as well. Ribavirin therapy, when we're talking about it, it is given through what's called a SPAG, which stands for small particle aerosol generator. A small particle aerosol generator. And what it does is give continuous aerosol via a mist tent. It is given over 12 to 18 hours a day for 3 to 8 days. It's given, I made a boo-boo, should be 0.8 milligrams per kilogram per hour. They need to wear the respirator mask. They can't administer if they're pregnant. And no contacts in the eyes because it will crystallize their contacts. And if you have to open the tent, you need to shut it off temporarily before doing so. So there is some issues here to giving that medication. It is recommended on a case-to-case basis based upon the concerns regarding cost, benefits, safety, and variability as well. Possible candidates then for ribavirin therapy would be those that are less than 6 weeks preterm or have congenital anomalies, those that are hospitalized and severely ill, and those who are immunosuppressed. RSV immune globulin, or RSV GIV, or Respigam, is an IV preparation of immune globulin G. This provides neutralizing antibodies against RSV. It's given to high-risk patients. It can interfere with the MMR and the varicella vaccine, so that is deferred for up to 9 months if they have had those. It is given monthly during RSV season. It can be quite costly then because it costs about $1,000 per infusion. Now, if you think about the type of immunity, you might need to go back and look at the types of immunity that would develop. And remember, that was your what? Artificially passive. Okay, because you're giving it artificial and you're giving it passively. So you want to make sure that you are remembering those things and not forgetting them. All right. Your Synergist, which is given to high-risk patients, is given monthly in IM injections as well. It does not interfere with MMR and varicella vaccines. It does cause pain and mild erythema at the injection site. Its recommendations for RSV immune globulin or Synergist is children younger than 2 with a chronic lung disorder, premature infants 32 weeks or lower, severe immunodeficiencies during the RSV season only. And don't forget the EMLA cream. If they're going to be coming in for these injections and you know they're going to be coming in, then they can put that EMLA cream on an hour before to decrease the pain at the site. Diagnosis of RSV, the clinical presentation, we're going to be doing what's called the nasal test. And when you do the nasal test, you do need to actually have a crash cart available. One of the things that they are doing now, it's not as bad since they started doing the nasal test, because they're actually just taking a swab in the nose, swabbing it really, really good, and sending that down to lab. Now, years ago, in some your rural hospitals, you may still see them doing it this way, is that you would go in and you would take saline and you would draw it up in a 3 ml syringe, and you would take about 1 ml of that saline. And you would take the saline and you would push that saline in their nostril, and they would gag, turn blue, and you think you were choking them to death. Then you would suck that back out real quick and get as much of that secretions as you could and put that in your syringe and send it down. Because of problems with children aspirating and having other issues, and crash carts need to be available during that testing. For most of the part, evidence-based practice actually says all you got to do is use the nasal swab now. But if you're using the test where they actually use the saline and the flush, then you want to have a crash cart available when you do that. Incentive spirometry, we've already been over that. We went over the incentive spirometry contest, and y'all were all winners because you all ended up doing it for me. All right, that's the end of this section. More to come. Thank you. Have a great, great day.